So, what is the basis of the anesthesia monitor and how it is done? So, it is a suppression of electrical activity of the neurons of the central nervous system. That is how most of the anesthetic agents act. And the EEG reflects the combined synaptic activity of both excitatory and inhibitory postsynaptic neuron activity, cortical neurons. So the EEG does not change in a linear or a monotonic fashion with changing anesthetic depth. That is and not all anesthetic agents produce similar EEG pattern. So these are all the basic things that have to be known about how the depth of anesthesia is monitored. And complex EEG signals is dissected to extract its core component with significant advances made in interpretation of the information that is made to contain. And I think all of you have seen an EEG tracing being done for neuro patients. It all looks like a very, very wavy pattern in a bizarre sheet of paper, unlike your electrocardiogram, which has got a specific pattern. If you look at the EEG, it is all the different types of wavy pattern that is having. So increased speed, flexibility, and economy of digital circuits, as well as advances in computer hardware and signal processing algorithms, have made the changes in the signal processing. This is the very, very important advancement or the technical improvement that has made the depth of anesthesia monitoring possible. Okay, so even though the EEG is a very, very rough estimate or the expression of the electrical activity of the neurons, these aspects of increased speed, flexibility, and advanced computer hardware with signal processing algorithms have made this electrical waves that are produced by the neurons to be analyzed using what is called the signal processing technology. And the methods have developed the compress, simplify, and display various process summaries of EEG data. And that is how we are able to achieve the presentation of the anesthesia depth of monitoring in various machines that we have. But there are limitations to this method. One of the major limitation is each machine or each monitor that we use to assess the depth of anesthesia, the manufacturing company makes its own proprietary algorithm, and it involves a lot of mathematical process. So unless one is very good in mathematics and computer knowledge, it is very difficult to understand each and every machine. That is the one limitation of that. And the earliest machine that we were started using is the BIS monitoring, and it has some components. How many of you have seen or used a BIS monitor so far in your training period? So Priya, have you used it?
Yes, sir.
You have used it. Can you tell me what are all the components? How will you attach it? You use it for a patient?
So 4 electrodes are placed in the forehead, sir.
Very good.
And
why 4 electrodes? What is the function of those 4 electrodes?
so to look at that burst suppression ratio.
Burst suppression ratio. Okay. So do they monitor only the electrical activity of the brain, or does it monitor something else also?
Muscle activity, electromuscle.
The frontalis muscle activity is also measured. Okay, that is a very, very important point that you have to remember. The 4 electrodes not only measure the electrical activity emanating from the neurons, but also the frontalis muscle, because the patient is under light plane of anesthesia during the process of his losing consciousness from the state of wakefulness. Without our own knowledge, we will be trying to raise our eyebrows and try to contract the forehead muscles, the frontalis muscles. That will happen. And even some of you would have noticed that during recovery also, when we try to wake up the patient, when you call them and say, open your eyes, if they are not fully awake, they are in a sedated state, they will raise the eyebrow and you can see the wrinkles happening on the forehead. Okay? So this reaction of the forehead is a part of exhibition of the depth of anesthesia. And that is the reason why you have these 4 electrodes to measure not only the cortical activity, but also the frontalis muscle activity, which is a part of exhibition of your depth of anesthesia. So the persons who described this were Sigel and Chamon, and it has a non-invasive adhesive sensors and the patient interface cable, a digital signal converter, and a microprocessor and a monitor. These are the components of this monitor. And which are the anatomic structures in the CNS involved in maintenance of our conscious state?
Cerebral cortex.
Cerebral cortex, okay.
Amygdala, hippocampus.
Pardon?
Hippocampus and amygdala, sir.
Hippocampus, amygdala, then only these 3. So the brainstem does not have any involvement in that.
Reticular activating system.
They are also involved. So the anatomic structures of the central nervous system that contribute to that are first brainstem, the pons, the thalamus, and the brain cortex, connecting all these things. Okay? And what is the mode of action of drugs producing general anesthesia? That's what I asked you now. It can be neuron hyperpolarization. This is the inhibition or decreased excitation. And what are the various receptors that are acted upon by GA drugs? Where are they located? One receptor I told you is the GABA receptor. Any other receptors? That also I think I told you. It's about GABA, nicotinic acetylcholine, and glutamate receptors or NMDA receptors. These are 3 main receptors in the brain which are acted by the GA drugs. And there is a glycine receptor in the spinal cord. And what changes are produced in the electrical activity by GA drugs? That also we have seen that it's a transition from low voltage, high frequency pattern of wakefulness to a slow wave EEG of deep and non-rapid eye movement sleep, and finally an EEG burst suppression pattern. So from when the patient is fully conscious and awake, it is a low voltage, high frequency pattern. Once the patient becomes go to the surgical plane of anesthesia, it becomes a slow wave EEG, deep non-rapid eye movement sleep pattern, and finally the correct surgical plane results in EEG burst suppression pattern. Now, you should have a clear understanding of what is this burst suppression ECG and its significance. Okay? So burst suppression is nothing but when you see the EEG pattern, there will be alternating periods of high voltage electrical activity followed by periods of near flat suppression. So you may have a pattern like this very fast once and then followed by totally flat lines. Again start with a high flat burst activity with a high voltage. And this alternate things can happen in pathological conditions like coma or in deep anesthesia, and in some neurological conditions like anoxic brain injury or encephalopathy and metabolic disorders. Now, why should this burst suppression will happen? Any reason for this? Why this is happening in coma or in deep anesthesia? Is it sort of, do you think it's a sort of protective phenomena? See, normally when you are awake, I told you, it is a regular pattern of electrical activity. Slow, deep wave, the low voltage, high frequency pattern that happens in wakefulness. But once you try to make a person unconscious, whether it is by pathological condition or by purpose, when you do it for making the patient unconscious to tolerate the nociception and surgery, there is naturally a reactive phenomenon in the brain. It doesn't want to become unconscious necessarily. So the brain tries to react, but it is not able to react in a full way because the drugs are suppressing that. So what it tries is on and off, it tries to get back to the wakeful state. At that time, there is a lot of electrical activity which results in the so-called burst. After that, the drug effect overcomes that and then it suppresses and there is a flat line or the suppression that is happening. And after some time again, the brain neurons are trying to come back to normal activity. So this sort of alternating stimulation and suppression results in what is called the EEG burst suppression. Okay? And this is being used as a percentage or the ratio of this burst to the suppression is used as to assess the depth of anesthesia. So if the frequency of stimulation comes down, that means you are taking the patient more and more deep because there is more of flat lines rather than the elevated lines or the elevated activity that is happening. So that is how the burst suppression has become a very important component of especially the entropy type of management. And apart from this BIS monitoring, there are recent things which are given more important is AEP. What is AEP?
Auditory evoke potential.
Auditory evoke potentials. So, and as I told you, Michael Tunstall, when he wanted to demonstrate the awareness, he said patient's limb will be isolated by raising the BP cuff and preventing any blood flow. And you tell the patient to be close to his ear that you flex your fingers, you flex your elbow. That means patient is able to hear what you are saying and obey your commands. That means auditory function can be stimulated by repeated signals. And that is the basis of auditory evoke potentials. And by calculating that response, they were able to find out whether the patient is really unconscious or the plane of anesthesia is adequate or not. So it's a response to the auditory pathway to sound stimuli, and it's calculated by repeatedly applying an auditory stimulus to the patient and then taking the average immediately follow each stimulus, thus eliminating the non-stimulus related portion of the EEG also. And compared to the raw EEG, AEP is less sensitive to artifacts than random in occurrence, and it can eliminate the EEG signal by repeated averaging also. So nowadays, this auditory evoke potential is considered more sensitive and more accurate compared to your BIS monitoring or entropy monitoring. And this picture, if you remember, it will be easy to understand how the various depth of anesthesia monitoring equipments are working. So initial thing is the raw data. I don't know how many of you are able to see this picture because it's not big enough. So you have the raw data which is being given to the machine, and then the information is collected and it is analyzed. That is where I told you the signal processing is a very important technology which has made this depth of anesthesia monitoring possible nowadays. And then it gives the ECG bar and analyzes that, and then it evaluates and then it gives the display. So there are three components: raw data supplied to the machine, then the information is processed and analyzed, then it is the knowledge is gained, and then the display is being done. So this is how all the machines act in the same pattern, and you will be seeing some of the newer machines that are being used. And this is the pattern which is used in the BIS algorithm, and various depth of anesthesia monitors which are in use now are the commonest and the oldest is the BIS monitor. Then we have another monitor called Narco Trend. Then there is a auditory evoke potential monitor. Then there is a PSA 4000, which is also called Patient State Index Monitor. And you have indication of consciousness monitor, IOC monitor. Then you have cerebral state monitor, and you have entropy module. Okay, so these are the 7 different monitors which are available now. And slowly these modern machines are also coming into vogue for usage other than your BIS and entropy, which are quite old, and then came the narco trend. So nowadays these monitors are also gaining importance. So we have to know a few things about each monitor. The BIS monitor, all of you know, it processes the ECG from a single channel EEG. Actually, how many electrodes you have to place for recording a proper EEG by a neurosurgical
12.
lab? Huh?
12.
16 electrodes have to be placed all over the scalp. Okay? Whereas here we are placing only 3 electrodes mainly for the electrical activity and 1 electrode for the frontalis muscle activity. So this is called the single channel EEG signal, and it gives a dimensionless number. What are the other dimensionless number we are using in your pencil wheel? Any other example of dimensionless or unitless numbers?
Reynolds number.
Reynolds number, very good. Then does pH have any unit?
No, sir.
No. Okay. So pH, Reynolds number, and the BIS index number all have unitless numbers. Okay? And the EEG is based on the technology which are available are other monitors which work on the EEG principle are entropy and narco trend, and also auditory evoked potential. And entropy, as we said, it also records the frontal EMG value also, apart from the EEG, and the data converted into 2 values that indicate the depth of anesthesia. And one is the response entropy, which indicates the patient's responsiveness to external stimuli, and signals early awakening during recovery also. So the response entropy we take into consideration during painful stimulus. For example, when the first incision is made on the abdomen or either side, you have to look at the response entropy. If the value increases, that means patient is in a lighter pain of anesthesia. Similarly, when you cut off all the anesthetics and during recovery, the response entropy should increase in value, indicating that patient is becoming lighter and he is waking up. So you can use this for assessing the response to noxious stimulus as well as awakening. Whereas the state entropy is used to assess the hypnotic effects of anesthetic agents on the brain. So state entropy indicates actually the suppression that is produced by the drug. And the target range for response entropy is 40 to 60, whereas state entropy value near 40 indicate a low probability of consciousness. So 40 for both these things indicate that that's a correct surgical plane. And narco trend is a technology using the same raw EEG with spectral analysis, producing a number of parameters, and the multivariate statistical methods are used to assess that, and it has got 2 methods of assessment: visual assessment of EEG as well as the Loomis deep sleep classification system. And the EEG visual classification, narco trend, it is not only the number display like your BIS and entropy, where from 1 to 100 you have the numbering system, and here you have the alphabetical or A to F stage also is there. So stage A means patient is fully awake, and stage F means patient is deeply anesthetized, and that is given as a display using the visual assessment of EEG. I will show you the picture how this is being displayed in the machine. And stage E indicates the appropriate depth of anesthesia. So in a narco trend, you have 2 methods of display of depth of anesthesia. One is the staging classification using the alphabets, and another is a number, which is again like other methods, other monitors. You have 0 to 100, where 100 is fully awake and 0 is electrical silent. And evoked potentials have this show response to stimuli. and their stimulus is based on the 8th cranial nerve activity by repeated auditory stimulus and signal acquiring using EEG. So once you give the stimulus to the auditory nerve, it reflects on the cortical area and EEG patterns are produced, and the electrodes are placed here in the mastoid process and not in the midline like forehead like your regular BIS and entropy monitors. And the next machine is what is called the patient state index, which is PSA 4000, what I showed you. It's again a 4-channel EEG monitor that collects information on frequency. And it gives a continuous numeric value. Again, here also the values are from 0 to 100 as it is shown in other things. And it has a very significant heterogenic variance of sedation, hypnosis, and to specified levels of specificity is more clearly given in PSA rather than. So the advancement in PSA says it is more accurate to even small changes in conscious state. And the components, as I showed you, these are the 4 electrodes which are placed. This is the index interface cable, and this is the monitor with the values being given, and there is a power button and all that. And this is the display in narcotrain. That is where I told you this is the visual display of the EEG signals, and this is given in the alphabetical range. So B1 means A is fully awake, F is fully sedated, and E is supposed to be the ideal one. So B means patient is still not fully anesthetized. As you are starting the induction, he is drifting from A to B, and you can see the numerical value is also there. So from 100, he has become lightly sedated to 85. So the narcotrend gives you these 2 methods of assessing the depth of anesthesia. And this is the relationship between the surgical stimuli, general anesthetics, and awareness. So when you cause a surgery, it is causing a stimulus, it is going to cause arousal. And general anesthetic is going to suppress the painful stimulation, and also the arousal it has to. So you can see the negative marker here. And this arousal increases the heart rate and blood pressure. And that also tries to stimulate the central nervous system to make the patient become more conscious. And if the patient is not in correct depth of anesthesia, he will try to react. He may even move if your muscle paralysis is not adequate. For example, if you are doing it in a spontaneously breathing patient, if the depth of anesthesia is not adequate, patient may react and he may move or burst and cough. All these things can happen. So muscle relaxants are mainly used to prevent this movement, and general anesthetics are mainly used to prevent this awareness. And if the patient becomes aware, its memory is affected, he registers this events that is happening, and post-operatively he may have a recall. So this picture will give you a very, very simple, easy idea why depth of anesthesia is very important and how it can be interfered with by the surgical stimulus and your anesthetic depth. How both of them are to be balanced to maintain a correct plane of anesthesia. And this is the entropy monitoring. Response entropy at 48 means patient is adequately anesthetized, and state entropy is 47 means patient is unlikely to be conscious, and the depth of anesthesia is very good during the surgery. And these are all the various responses. So the display will show you both response entropy and the state entropy in the entropy machine. And this is how the frequency rate happens. And in AUT monitoring, this is how the whole thing is, electrodes are placed. It is not placed like your regular BIS monitor or entropy monitor. Then children, when you want to do the AUT, is more sensitive. That can be done by putting this headphones and then try to record that. And this patient state index is a monitoring system which analyzes data from 4-channel electroencephalogram. Unlike your single-channel EEG which we saw in the earlier machine, this analyzes a 4-channel electroencephalograph. And this is how the whole monitoring screen will be showing. And it also assesses what is called the density spectral array activity, and it individually assesses the right and left side of the brain. That is another important advancement that has taken place in this. And DSA contains left and right spectrograms on both sides of the brain. And PSA monitor, initially called the PSA 4000, is also one of the ACD line monitors. It's the company which is producing this. It's a new generation device. And the option for storing and downloading patient data for future use, as well as monitoring bilateral brain function and symmetry with this density spectral array are all available. So this is going to be the monitor of future, which is going to tell you all the importance. So instead of dealing with MAC and the deglutition movement and lower esophageal sphincter activity, which are all not used anymore, I think you should incorporate these points in your answer, which are the newer developments that are taking place in the depth of anesthesia monitoring. Okay.
Yes, sir.
So